Good afternoon and good morning, everybody. And thank you for coming to the Defeat Malnutrition Today West Health webinar, Bridging the Silos of Health and Social Malnutrition Care. We are so excited to have you, and we are really excited to get this presentation underway. So I'm sure most of you have used GoToWebinar before, but just a little housekeeping. You can open and close your control panel using the little arrow that is highlighted. You can join the audio via your computer or by dialing in. And we ask you to submit your questions and comments via the questions panel, and we'll be taking all questions at the end of the presentation. So now I'm going to introduce our presenters today. We have Jean Terranova, who is the Director of Food and Health Policy at Community Servings, a Boston-based not-for-profit that prepares and delivers high-quality, medically tailored meals to individuals coping with complex illnesses. A graduate of Suffolk University Law School, Jean has worn many hats as a social justice attorney and advocate. Next, we're going to have Jennifer Sanat, who recently joined the Serving Seniors team as the Vice President of Clinical Services, bringing nearly 20 years of experience in aging services and supportive housing in both nonprofit and county government systems. She is responsible for the integration of social work, nursing, dental, and wellness services. Finally, we're going to have Susan Saffel-Schreier, who is a professor, registered dietitian nutritionist, and certified gerontologist in the Department of Family and Preventive Medicine at the University of Utah School of Medicine in Salt Lake City, Utah. Her career spans 38 years and involves a large breadth of experiences in nutrition, aging, gerontology, and geriatrics. She currently directs the geriatric education for the University of Utah Family Medicine Residency Program. And now we're going to have a brief word from Bob Loncato, who is the National Coordinator of Defeat Malnutrition Today.
Thank you, Meredith, and good day to everyone. And I join Meredith in being very excited about this second webinar with West Health on this very important topic and bringing this topic of malnutrition to the community. And we find that these webinars are informative in many ways, but it's the feedback we get from the people who participate and attend the webinars that we're very especially proud of. And so I look forward to the comments, and we look forward to continuing our work with West on this very important topic. And do I introduce Brenda, or do you, Meredith?
You introduce Brenda.
Oh, my goodness, my favorite thing to do. There we go. Brenda Schmidt-Henner, Senior Director of West Health, who's the architect of this whole undertaking that we're doing with West in this area. And she, as I said, is a Senior Director at West, but more importantly is really the driving force behind moving this topic to the point where we are. So Brenda, please take it over.
Thank you, Bob. Well, many of you may be unfamiliar with West Health, and you might be wondering, who are we and why are we interested in malnutrition? Well, it's because West Health is creating and fostering innovative care models that improve health outcomes and better address both the medical and the non-medical needs of older adults and their families. And it is our institute, our policy center, and our foundation who are all working together under the same umbrella of West Health. And we have a shared mission to slow the trajectory of rising healthcare costs while improving access to and enabling successful aging for our nation's older adults through our research, policy, advocacy, and philanthropy. Next slide. I'm confident that you all have heard the statistics. The human and financial toll of older adult malnutrition is staggering. Every day, 10,000 people turn 65, and by 2040, 21% of our population will be 65 and older. And I think we can all assume that as this population grows, it is very likely that without addressing both the medical and the social risk factors that are associated with malnutrition, this annual financial burden and the negative impact on the lives of older adults will continue to rise. Next slide. And it is because of the impact of malnutrition on successful aging that in February of 2018, West Health convened a senior malnutrition visioning session in Washington, D.C. And at that summit, we engaged with national leaders in healthcare, aging, senior nutrition, policy, and research, and we exchanged innovative ideas to advance a comprehensive malnutrition care plan for older adults. And the output of that session was this multi-year roadmap. And it was following this visioning session that West Health joined Defeat Malnutrition Today to support improvements in the identification of senior malnutrition and its associated social risk factors, community intervention, evaluation of best practices and research, and to advance policies that provide incentives for quality measurement and reimbursement for malnutrition-related activities. I'd like to thank you all for joining us today for this webinar.
Great, thank you, Brenda. Next, we are going to have Jean from Community Servings.
Great, hi, thank you so much for the opportunity to present today. Brenda, Bob, and Meredith. I'm here from Community Servings, and next slide, please. Here to talk about the role of medically tailored home delivered meals in holistic patient-centered models of care. And this topic today of bridging the silos is really on point with the work that we're doing. As you'll hear, we're starting to make some inroads into having our services reimbursed through innovative healthcare payment and delivery models, but there really is a long way to go to make this an integrated service that is part of patient-centered models of care. Next slide, please. Community Servings was founded about 30 years ago to provide home-delivered meals to people who were coping with AIDS wasting syndrome. And at the outset, we served 30 clients a day in 2 neighborhoods of Boston. And we've evolved to serve medically tailored home-delivered meals to 1,200 clients a day, regardless of their illness. We're now in 21 cities and towns in Massachusetts, but we'll soon have the capacity to serve the entire state. We're part of a national coalition that many of you might have heard about called the Food is Medicine Coalition. And a program of the coalition is called the Food is Medicine Accelerator, which is working towards expanding these services to unserved and underserved communities throughout the entire country. Next slide. We and others in the Food is Medicine Coalition serve high-need, high-cost patients who have multiple chronic conditions. And most of our clients, 2/3, have multiple diagnoses, and the vast majority, it says here 90+%, but really you're talking about very close to everyone that we serve experiences poverty. You can see the diagnoses. These are the primary diagnoses of people that we serve, broken down by percentages. It's still quite a high amount of people that we serve have HIV and AIDS, and then in addition, cancer, renal, diabetes, etc. But what's unique about our population is that most of our clients are coping with a host of illnesses that require very tailored and complex nutrition intervention. So if someone has HIV and AIDS as well as diabetes, you're talking about need for a high protein diet that is also going to be consistent with the needs for someone who has diabetes, so whole grains, lean proteins, etc. Next slide, please. So just a word about how the program is designed. We and others in the Food as Medicine Coalition do mostly scratch cooking using fresh, whole ingredients. Our menus are developed and executed by registered dietitian nutritionists and an executive chef. We offer 15 different medically tailored meal selections, and the registered dietitians can customize those selections in up to 3 different combinations. And then they will offer the dietitians an initial nutrition assessment and optional ongoing nutrition counseling. And then we're always evaluating and looking towards quality improvement. You can see a quote by a client who's received this service, and it just really does have an impact not only on, and you'll hear this in a minute, healthcare utilization and costs, but also, just as importantly, quality of life. Next slide, please. So some of the research, and we have 3 studies that have been peer-reviewed and published over the past 2 years. And what they show is that the service helps reduce utilization of acute care healthcare services, including hospital admissions, emergency room visits, and ambulance services. And then most recently, admissions into skilled nursing facilities. And then, as you would imagine, the reduction of the use of these services also translates into a reduction of medical costs. In 2 studies that have been published in JAMA Internal Medicine and in Health Affairs, the number was 16%, and that is net the cost of the meals, and that's on a monthly basis. The service also improves health outcomes for people with complex illnesses and improves self-efficacy and quality of life. Next slide, please. So how have we been trying to integrate the services into healthcare payment and delivery models? Well, we have been working with managed care plans to serve individuals who are duly eligible for Medicaid and Medicare, and that's not just older adults, but in Massachusetts there's a plan that is specific to a Medicaid plan that is specific to adults with disabilities who are under the age of 64. So it can be 65 and older and 64 for disabled adults. We are piloting reimbursement through a Medicare Advantage plan for people with congestive heart failure and a recent hospital admission. And then we're pursuing contracts through a new program through the Massachusetts Medicaid program called the Flexible Services. And this is these are funds that are available for nutrition, housing supports for people with complex health needs. And we qualified just for data security purposes and HIPAA compliance as a first-tier downstream and related entity, again, to really try to integrate our services and start speaking the language of healthcare. Next slide, please. So, as I mentioned, we are making progress, but there still is a real need to break down silos. Because there is not uniformity, for example, in screening and referral criteria. So who is eligible for the service, how are they screened into it, and how is the referral made? There is lack of consistency in how the program is designed for different healthcare models. For example, how long the service should take place, whether nutrition assessments should be included, and whether meals should be provided to family members, because as you can imagine, if a sick person is the head of a household or has a sick spouse, they're often going to either give that meal away to the other family member or divide it, and so it's not going to have the impact that we need it to have. There needs to be consistency on evaluation in the medical system, feedback from both the client and the medical professional, and then what it means to keep improving the quality of the service. Next slide, please. This kind of lays out what our kind of gold standard is for our vision to break down the silos. We are working with the Center for Health Law and Policy Innovation at Harvard Law School on what we are calling the Massachusetts Food is Medicine State Plan, and the vision that's laid out here is consistent with what we have developed in the plan through a rigorous process of data collection and stakeholder engagement. There needs to be better provider knowledge and screening in the healthcare system. There needs to be bi-directional referrals for the referral system and seamless integration with the platform where the referral is being made and through technology. The service needs to be equally available to everyone, regardless of where they live in a state or within the country. And then there needs to be sustainable funding for the service that the community-based organizations can rely on. So that all requires systematic change throughout public and private sectors to support these services. And thank you very much.
Thank you so much, Jean. That was fantastic. Next up, we have Jennifer from Serving Seniors.
Thank you so much, Meredith. Truly honored to be part of this distinguished panel and really appreciate the opportunity to participate. Next slide, please. And next again, please. So the mission of Serving Seniors is to help seniors in poverty live healthy and fulfilling lives. And since 1970, we've been transforming the aging experience through our innovative approach in the provision of comprehensive services. In April 2010, Serving Seniors opened our flagship site, the Gary and Mary West Senior Wellness Center in downtown San Diego. In 2020, our agency will actually be celebrating our 50th anniversary. Our president and CEO will be celebrating his 25th, and we will be celebrating the 10th anniversary of the Wellness Center, so lots to enjoy and celebrate in the coming year. There are about a dozen or so affordable housing communities for low-income seniors in the downtown San Diego area, and our Wellness Center is centrally located and accessible by public transit, and we serve more than 3,000 seniors annually at the Wellness Center. Next slide, please. Here are just some basic demographics of the clients that we serve. So again, fairly even split between genders. We do have a significant Mandarin-speaking population based on our location as well. And I think the key takeaway here is that 80% of those we serve live at or below the poverty line. Next slide, please. So Serving Seniors offers innovative, whole-person, community-based programming and services that are really focused on the clinical, social, psychosocial needs of vulnerable older adults. Next slide. So a hot meal is really the #1 reason that individuals seek our assistance. We serve over 620,000 meals annually between our 10 congregate meal sites and our home-delivered meal program. We are the largest provider of home-delivered meals to seniors in San Diego, currently operating 11 different home-delivered meal routes, serving more than 600 individuals. At our congregate sites, seniors are actually served their meals, which I think really provides a more dignified eating experience for them. And those meals are often served by volunteers. So we have more than 40 local companies, organizations, schools, and civic groups that regularly come in to participate and help serve our individuals. A brief initial nutrition intake is completed for those interested in participating in our congregate meal sites and for our home-delivered meal program. For home-delivered meal program participants, we also do an assessment for ADLs and IADLs, and for both, a nutrition risk status is completed. Next slide, please. So nearly 5,000 unduplicated clients are served each year by Serving Seniors through our vast array of wraparound services. So in addition to nutrition, we provide social services, health and wellness, activities and events at the Wellness Center, as well as at 6 supportive housing sites, 2 of those that we own and 4 others that we contract with, and feel that the pairing of social service case management with nursing services is really critical to meeting the full scope of the needs of this vulnerable population. Our social service team offers full case management services, including assessment, care coordination, supportive listening, and referrals to community-based programs and other various benefits and entitlement programs, really to help enhance independence and overall support for older adults. Our nurse case managers provide one-on-one consultations, health education, medication reconciliation, basic vital checkups, and really serve as a liaison to clients' medical teams. We also have a psych nurse on site twice a week to really assist with mental and behavioral health challenges that we might be experiencing. We offer robust lifelong learning and engagement opportunities at all of our sites, things such as exercise class, brain fitness, travel groups, arts, crafts, bingo, table tennis is very popular. And we have a senior-led civic engagement group that's really addressing important issues for older adults through advocacy, letter writing campaigns, and legislative visits to the state capitol. We also provide transitional housing for homeless seniors in being able to provide about 90 to 120 days of housing while they work intensely with our case management team to find permanent supportive housing. We currently own 3 affordable housing communities throughout the county and have 3 others in various stages of development. We have a multitude of collaborative partners really helping to provide this whole person-centered service and support, and we have a really unique and extremely important collaboration with our on-site dental center. Next slide, please. So we developed a whole person, holistic model in collaboration with our dental team. So just to kind of give you a sense of how this works, our care navigators conduct a comprehensive geriatric assessment for each individual that is interested in accessing the dental services. And this assessment really helps us begin to identify any challenges, barriers, anything that may be going on for the individual so that our team can begin to assist that particular individual with those issues prior to and throughout the course of their dental services. It's about a 27-page document really touching on various aspects from health, functional ability, mental health, oral health, and nutrition. The nutrition screening that we do includes questions related to meal frequency, money to buy food, weight fluctuations. Is an individual having worry about not having enough to eat? We also conduct the Geriatric Oral Health Assessment Index, which asks over the past 3 months, has someone had limited food due to problems with their teeth or gums, had trouble biting, swallowing, chewing, or speaking, had limited contact with others due to conditions of their teeth or dentures, or have they experienced worry or been nervous or self-conscious because of their teeth? Next slide, please. So the CGA encompasses various social determinants of health, nutrition, medical, quality of life, using just a series of validated assessment tools, and this is just an example of some of those tools that we use throughout the course of the CGA. Next slide, please. And so based on the self-reported responses that we get from individuals, metrics are devised to show risk levels, high, medium, and low, in one of 3 categories. So there's general, mental, and dental. And so we are able to make referrals to case management, nursing care coordination, mental health, and nutrition services based on these metrics and the overall outcomes of the assessment. Since we started conducting the CGAs in 2016, nearly 1,400 CGAs have been completed, and there have been hundreds of referrals made to case management, mental health, nurse case management, housing, nutrition, and other community-based resources and supports. Next slide, please. So with oral health truly being the gateway to overall health, there is just tremendous interconnectedness between improved dental health, improved general health, and increased overall well-being. And that integration of services also improves the overall coordination of care for the individuals that we're serving. So this slide here just sort of represents the components of the CGA and then the collaboration that we have with the dental center. So individuals seeking those services are asked to do an oral health education class. They do a basic dental screening prior to the start of any dental work. And then you can see the connection with our nursing care coordination, mental health, and social services. And there are just hundreds of success stories really coming from this collaboration where individuals and their quality of life have been completely transformed because of the services that we've been able to offer. There are just really some incredible before and after pictures of the dental work that's been completed that have allowed individuals to be able to eat properly, to even be able to smile as they had not been able to do so before, and just multitudes of heartwarming notes of gratitude for the services that have been offered. Next slide, please. Serving Seniors has close to 30 on-site collaborative partners. Here's a list of a few of those, and one I'd like to note that's our newest collaborator is with our county's Health and Human Service Agency's eligibility operations. So for individuals in California receiving SSI, as of June 1st, they now became eligible to receive CalFresh or our food stamp benefits. So by having a county representative on site at the Wellness Center, we now have that direct link for individuals to access the food stamp application process, as well as have a direct link to the Medicaid process, benefits, and supports. We're also developing a partnership with a local federally qualified health center to really enhance the scope of health services offered and to decrease health access barriers for those that we serve. Next slide, please. So again, I've been with Serving Seniors for almost a year now and just continue to be in awe of the breadth and scope of services that are being provided for low-income seniors. We're a relatively small team with only about 70 employees and are continuing to grow and expand to meet the tremendous needs of older adults in our community. And I just thank you for the opportunity to share what we do.
Thank you so much. That is really interesting work you're doing. Finally, we are going to have Susan from the University of Utah.
Good morning or good afternoon, wherever you're at. Thanks for the opportunity to speak today, Meredith and Defeat Malnutrition and West Health. I'm wanting to share with you a current grant that I'm working on through the Administration for Community Living. It's part of the Innovations in Nutrition Programs and Services. It's a 2-year grant, and we are in the final months of the second year. And thanks for forwarding that slide. The title of the grant is Bridging High Quality Malnutrition Screening, Assessment, and Intervention for Older Adults from Hospital to Home. Many of you, our 2 earlier speakers, have mentioned the importance of, coordinated care and providing high quality food and nutrition. And I was really impressed to hear terms like comprehensive senior malnutrition care, holistic patient-centered model of care, need to break down the silos, very much so, comprehensive geriatric assessment. That's what this is all about. We're diving in a little more so into these areas and trying to tease this out. I also want to recognize there's 2 fellow RDNs on the project that have been wonderful, Charlotte Vincent and Amy Covington. Next slide, please. Just want to back up just a second and kind of come back to this comprehensive approach and how we deliver health care in the United States. Many think of health care and medical care as one and the same, and that's really not the case. And I think that causes us more health dilemmas than we really need to produce. So healthcare is anything from, clinics, hospitals, to someone in the community providing a service, a health service. And so medical care is part of that, but it's not totally healthcare. So I think we need to rethink when we say that term, what does that mean? And I like this, the blind men and the elephant example of coordination of care. If the fellow that's checking out this elephant's ear, if he's not chatting with the person checking out the tail, then of course we have troubles. And this kind of fits in with malnutrition too, because malnutrition is so complex and multidimensional that we need to have this communication, and that's part of this bridging. The grant is really a transitions of care type approach. Next slide, please. Malnutrition cycle. It rears its ugly head in many different settings, and if we don't address it fully, then it's carried on, and then it can reintroduce itself in another setting and be very costly, along with reducing the quality of life. So it's so important that we address malnutrition fully. Again, from what our earlier speakers said, have noted, and the idea of this comprehensive assessment. Next slide, please. So just an overview of the project we've doing right now. It's joint. It's between the University of Utah Hospital and Clinics and through the Utah State Division of Aging and Adult Services and several of their AAAs. Again, we're looking to develop high-quality malnutrition home visitation program such that an RDN will go into the home and do this comprehensive nutrition assessment so that we can look at all the aspects and hopefully reduce, in the case of our study, rehospitalization. So the main outcomes, as I've alluded to, is producing this home visitation model, having RDNs direct this as they're trained in assessment. It's wonderful that there's a lot of screening going on and at different levels and at different types, but the screening needs to go the next step, which is the assessment, so that we can have objective data. And then, of course, as I've mentioned, there needs to be a full complement of agencies and programs involved in addressing the malnutrition as needed per the individual. Next slide, please. Just briefly, this is a study design. And as I mentioned, we're working with Aging and Adult Services, that is the University of Utah, the hospital and clinics. We started out working with care managers and the nutrition care services, but I'll mention how we've expanded that in just a minute. To qualify for the study, they need to be recently discharged from the hospital, and recently we say 60 days. Some people say that's very generous, but we believe that you need to get home, you need to settle in, and then realize that, hey, I guess I can't fully address my malnutrition or my access to food or whatever issue might be related to the malnutrition. Anyway, so 60 years and older, so they can qualify for Meals on Wheels, and then the referrals are sent to the RDNs, and we have there's two groups. There's an intervention and a control. The intervention, they get an initial nutrition assessment, a full nutrition assessment, and then we have monthly visits and reassessments, and then a regular phone calling. In the control group, we are calling them. On the initial assessment, we provide them with some basic nutrition information, and so on those calls, we're following up on healthy eating, and then just checking, are you still at the same address, and have you been admitted to the hospital recently? And we haven't started to analyze our data yet. That's coming in a couple of weeks. We have a couple of participants that will be finishing in that time, and so I'll hopefully be able to share that with you in the future. Next slide, please. I put this slide on here because with each partner that we've had, we've really had to detail out flow charts on the process of referral. It's very unique to each setting. Each AAA has their own flow chart that we've had to sit down and work through. And I just put this one on here because this was probably one of our more complex ones. We needed to add an additional consenting step with this particular AAA. So we have an IRB with the University of Utah, and we have an IRB with the Utah Department of Health. And so then we had to add a third component. It's all for patient safety, client safety, and but it's just teasing this out so that the referral process can go smoothly. Next slide, please. So just to give you an idea of the evolution of this project, just as, again, earlier has been mentioned, the silos. A lot of silos, a lot of trying to protect one's job over committed staff. I mean, it's a multitude of different reasons, and trying to understand and assist with that is important. One other thing we found out is continual training is extremely important, as well as contact. We were initially going in and doing a training in the beginning and then just kind of following up, and that wasn't working. We needed to keep malnutrition on the table and assessment on the table. As an example, the AAAs, they are obviously doing screening, but assessment isn't part of their programs generally speaking, and so we needed to keep that front and center. And then active recruitment. We, as I mentioned, we blossomed out, you might say. We are now looking at hospital to skilled nursing to rehab to home, and we have the ability to do that within our hospital system. And so we follow the older adults till they make it home, and then we go from there. Next slide. So with that, that is our project in a nutshell, and I want to thank you for the opportunity to speak. Thank you.
Thank you so much, and thank you to all three of you for a very fantastic presentation. So we do have a couple of questions that have come in, and I am going to go ahead and ask these. I think that I know that at least one is for Jennifer, and I think there's one that could be addressed by Jennifer or others. Please, if you have questions, go ahead and type them into the question box, and we will go ahead and start. Jennifer, is the comprehensive geriatric assessment being used for all clients coming in the door, or just those where dental need is expected?
Great question. It was originally developed to work directly with our dental clients. What we are looking to do is have that be the standard assessment for all of our programs across all of our sites. We're right now in the middle of transitioning from one web-based database to another, and so just run into a little bit of challenge, but our goal is to have that be the standard assessment tool that we're using across all sites for all clients.
Great, thank you. So I think this question might be for a couple of you. One person asked, most behavioral and mental health challenges are related to nutritional deficits or gut biome dysfunctionality. How are you thinking about integrating these two spheres of clinical influence, which have historically had little to do with one another?
Jennifer, I think this would be a really great question for you to answer.
Great. Certainly fascinating, just thinking about the gut biome and the impact that has on behavior. As I mentioned, we do have a psych nurse on site twice a week that's working with our team as we're looking at different challenges, and know that definitely is an area that we want to expand, knowing that the scope of different challenges that we're seeing currently goes a little bit beyond what our team is able to handle now. So open to to looking at those relationships, those opportunities to really delve a little bit deeper in what that relationship is like, what kinds of interventions and different types of approaches we can put into place, not only here at the Wellness Center, but also in our housing sites as well.
And this is Brenda as a follow-up. I think that this question highlights the importance of screening for social risk factors that are associated with malnutrition. Certainly understanding and screening for mental illness, depression, and many other mentally related disorders or cognitive deficits is really critical to basically understanding why that person may be at risk for malnutrition and helping them connect to the most appropriate services and supports that will address that risk.
Great, thank you. So this question is, I believe, for Susan. Should the RDN working with the AAA see all clients with a nutrition risk score above 6 to doing more thorough nutrition assessments?
The determined risk score has actually been a great tool. We were quite surprised because it's not validated. But and this is, again, we haven't opened up the data yet, but our study is a single blinded, so we can make some general observations. And wherever you decide your cutoff is, and I think you said this was 6 for some people have played around with that a bit, but we have found that is shall I say, spot on. Most of those folks that are referred to us from the determined screening are definitely at nutritional risk. There are some false positives. There are some referrals that are made that the client or the patient is not actually malnourished. So yes, I think if the screening is positive, it deems a full assessment.
Great, thanks. I believe this question is for Jennifer. Are you assessing hearing deficits when you do the comprehensive assessment?
Currently we are not, but that is something that we are looking at implementing with our community partnership with the local federally qualified health center, just knowing that is an important facet. Just currently don't have the capacity at our wellness center to do that, but that is, I think, a very important factor to look at as you're looking really at that whole person wellness.
Great. So we do have another question, and I think this could be for all three of you. Since loneliness is a huge causal factor in elderly illness, how do we encourage seniors to get out, i.e. eat in a congregate site, rather than encouraging staying at home with home delivery?
This is Jennifer with Serving Seniors. One of our models is to really bring the congregate meal sites to the housing sites. So looking at different ways to partner with housing communities that maybe have that general community space that it could accommodate the meals, looking at providing those socialization activities as well to really help build that sense of community within each of those housing sites.
I can comment in that many times the client, patient is unaware of transportation, of the different activities, and letting them know that these are available, and maybe finding ways for them to get there via a friend or through the transportation that's offered by our AAAs. It changes their thoughts about it, and it's great. It's so important for them to get out.
This is Jean. For the community serving clients that we serve home delivered meals to, they are generally not well enough to be able to go to a congregate site, and so that's why we emphasize the importance of providing meals to family members to keep that sense of community and reduce isolation. But then within the Food as Medicine state plan that I mentioned that we're working on in Massachusetts, we're really trying to emphasize the need to make appropriate referrals. And so if someone is well enough to go to a congregate site or to a community-based setting, that would be what we would recommend.
Thank you. Questions are starting to slow down. I do want to make a note that the slides will be available on the Defeat Malnutrition Today website in a PDF. I think that is actually it, unless folks have any other questions. We are getting some thank yous, so I'd like to echo that. Thank you so much to our presenters.
Thank you.
Thanks.
Thank you for including us.
All right. I think with that, I'm about to end the webinar, and I thank all of you so much for coming and attending today, and really, really appreciate your attention.
Thank you.
Thank you.
Thank you.
Thanks.